I think that was a very nice, eloquent talk by Dr. Gayatri. I think that was very thought-provoking too. So now moving on from basic research science to clinical science. My topic is defining sepsis in a patient with small size liver graft. I'm going to cover my topic under these headings: definition, what is the burden and the significance, and how sepsis affects the overall outcome of the liver transplantation, source of origin of the sepsis, bacterial and fungal, these two I am going to cover, the timeline of sepsis, post-transplant period, sepsis and severe sepsis, and what are the risk factors, how the incidence of sepsis is different between small graft and normal sized graft, any difference between left and right lobe graft, and depending upon the type of the etiology of liver failure, does it have any consequence on incidence of sepsis, and subsequently ILB's data. So small graft, I would mean in DDLT when we are going for a split and giving a partial liver graft to either an adult or pediatric patient, or else in live donor setting, the small graft could mean either GRWR of more than 0.8 or standard liver volume and graft volume ratio more than 40%, or less than both the parameters. Coming to pathophysiology of sepsis in small for size syndrome. Small for size syndrome doesn't happen with all the small grafts. It's limited to certain small grafts, in which it will lead to early allograft dysfunction, which can lead to host immune dysregulation, and this will ultimately give a scope for sepsis to set in such kind of patients. So coming to definition, which was my the main aim of going to this talk. So several definition has been used, that is CDC definition, sepsis 2 guidelines and sepsis 3 guideline. This is the guidelines which has been changed from initial sepsis 1 guideline, which is mainly based on CDC definition, and followed by sepsis 2, and the newer definition which came up recently is sepsis 3 guideline. The sepsis 1 guideline, as we all know, focuses on that systemic inflammatory response syndrome in the setting of a source of infection. These are the parameters that is used, as you all are aware. Any 2 or more parameters along with a focus of sepsis defines sepsis as per sepsis 1 guideline. Sepsis 2 guideline has been more objective in terms of looking into general parameters, laboratory parameters, and clinical parameters. The newer definition, sepsis 3, which came up in 2016, it basically focuses on organ failure score, that is SOFA score, with a quick SOFA score being used for sepsis screening, and the change in SOFA score which is used for definition for sepsis 3 guideline. These are the parameters that is used. In sepsis 1 and sepsis 2, the terms which are used are sepsis, severe sepsis, and septic shock. But in sepsis 3, they have made severe sepsis as a redundant, because this is almost always covered along with septic shock. So with sepsis, severe sepsis being defined as SIRS, meeting the criteria for SIRS, which is as a result of infection. In sepsis 2 guideline, all the inflammatory markers, as you can see, the hemodynamic parameters, which include the systolic blood pressure of less than 90 millimeter mercury and mean arterial pressure more than less than 70, or a decrease in systolic blood pressure of more than 40 millimeter mercury, or it should be less than 2 standard deviation. And the organ dysfunction has been defined as arterial hypoxemia and oliguria and coagulation abnormalities, ileus, and thrombocytopenia. But in sepsis 3 guidelines, the severe sepsis has been made redundant. And the definition involves suspected or documented infection. Both the suspected and documented infection are taken into consideration with more than 2 units SOFA point increase or certain change in SOFA point, that amount to be defined as sepsis. And septic shock is defined as sepsis or vasopressure therapy when it is needed to maintain the mean arterial pressure more than 65 mm mercury or lactate more than 2 millimole despite adequate fluid resuscitation. So this is the SOFA score, which takes into consideration 6 parameters with score ranging from 0 to 4, the baseline score being 0, or any change of score more than 2 as per sepsis 3 guideline would be considered as sepsis as per the definition. This is the more elaborative definition of sepsis as per the sepsis 3 guideline, in which the SOFA score more than 2 points as a consequence of infection. This more than 2 SOFA score change would lead to mortality risk of approximately 10% above the patients who don't have sepsis. Whereas the septic shock, which is associated with underlying circulatory and cellular or metabolic abnormalities, which is profound enough to increase the mortality, and this is associated with increased mortality risk of almost, which exceeds 40%. Hence, that determines the outcome in organ transplantation setting. Coming to use of these guidelines in the organ transplantation setting, I could find very fewer literature on using these guidelines. One article actually looked into the sepsis 2 and sepsis 3 criteria to identify sepsis in liver transplantation patients, that is LDLT patient, published from Japan, published recently. 66 patients were included. They looked into early post-operative sepsis, which was diagnosed in 14 patients as per the 3 guideline and 15 patients as per the sepsis 2 guideline. There was a quite good overlap between two. And sepsis 3 guideline, however, detected the sepsis earlier in patients, at least 50% of the patients, and at the same time as sepsis 2 in 28% of the patients, whereas the sepsis 2 guideline detected sepsis early in 21% of the patients. And at the same time, they also looked into the change in SOFA score, which is if there has been more than 4 points of change in SOFA score. The 3 guidelines did quite better in diagnosing the sepsis early in their cohort. And this is the graph which shows that this is the sepsis 3 guideline, which detects the patients with sepsis and preempt sepsis earlier than the sepsis 2 guidelines. So this basically concludes saying sepsis 3 guideline is better to detect sepsis in organ transplant patients too, in addition to other patients in ICU setting. Coming to definition, in particular to solid organ transplantation or liver transplantation as per AST infectious disease working group, the definition has to be based on clinical and microbiological documentation. All infectious syndromes should be categorized into one of the following, that is respiratory sepsis or primary bacteremia, urinary, liver or biliary tract like cholangitis, CMV infection, unknown origin fever of unknown origin, and GI tract sepsis, and skin and soft tissue, which includes surgical site infection, and intra-abdominal, that is deep organ space infection. Where no microbiological etiology is established, in those cases, clinical and radiological documentation are used to categorize infection. Bacterial pneumonia, how to define this in setting of organ transplantation? The pneumonia is defined as presence of one or more of the following symptoms, along with chest X-ray and CT scan showing pulmonary parenchymal disease. The definitive diagnosis is based on meeting the above criteria in combination with a positive culture from either sputum or bronchoalveolar lavage or lung biopsy. In the absence of one or more of these criteria, we should use probable pneumonia. We can still consider them as sepsis from lung origin. Coming to intra-abdominal infection, which is a common site of infection in case of organ transplantation, particularly in the liver transplantation. The definition should be based on the CT and ultrasound identified source, or that can be defined on laparotomy too. The microbiological evidence also includes includes the either culture from the tissue or fluid or in a new drain. But in the setting of pre-existing drain or indwelling catheter, indwelling drain, the definition of sepsis should be a little bit more. We should be more skeptical in terms of there has to be the clinical correlation, because the older the drain, the more the probability of colonization. Cholangitis, as you know, is defined by presence of jaundice, abdominal pain, and deranged LFT, and a fever. Bacteremia must be documented in positive blood culture and should be characterized by its source and accompanying syndrome. The example of potential sources which can lead to bacteremia are central line catheter-related bacteremia, or pneumonia, or intra-abdominal infection, or surgical site infection. The contamination should be differentiated from true bacteremia, particularly when there is indwelling catheter. We should have peripheral blood culture rather than looking at the existing catheter culture. At the same time, we should be looking at if a single positive culture of coagulation negative Staph aureus is found, it should be considered as contaminant rather than being concluded as definitive bacteremia. Coming to fungal sepsis, the definition that is used is usually by the group European group for therapy for cancer, and mycology study group that was published in 2008. All the criteria has been divided into proven invasive fungal infection, probable, and possible. In proven invasive fungal infection, we have to have direct evidence of fungus in the tissue, whereas in probable, we can have clinical and mycological criteria along with a host factor which suggests that the host is immunocompromised or dysregulated immune response from the host. Possible fungal infection is usually doesn't need mycological criteria, but there has to be an immunocompromised host along with all the clinical criteria that is used for fungal infection. So mycological criteria is not mandatory in possible fungal infection. In most of the subsequent definition, they tried to minimize the scope of possible fungal infection rather than expanding, and they try to expand the possibility of proven or probable fungal infection. These are the criteria which is used for mycological criteria and host criteria. In the subsequent definition of host criteria, the solid organ transplantation recipients has been included as a host factor. These are clinical criteria for lower respiratory tract disease and tracheobronchitis and sinonasal infection, which is otherwise called rhinocerebral fungal infection. So the same group has redefined the fungal sepsis in 2020, where they have tried to address the shortcomings by including the patients which are unsuitable for previous definition, particularly in the setting of ICU and pediatric patients. And they concluded that the data were insufficient to establish appropriate threshold for detecting galactomannan serum or tissue galactomannan, and there were uncertainty about beta-D glucan, serum beta-D glucan. They try to again define probable fungal sepsis more and reducing the scope of the possible fungal sepsis. So these are the criteria has been used by this group in year 2020 for molds, yeasts, and pneumocystis fungal infection. Coming to sepsis in liver transplantation, particularly bacterial sepsis, these are the evidences I have gathered in a table. This is first study published in year 2016 for 63 patients. They found that the incidence of sepsis is 46%, and the survival in patients with severe sepsis group is quite low in comparison to those who didn't have sepsis. This group published in 2008 from Germany, they looked into the incidence of sepsis in both the LDLT and DDLT setting. They found that the overall incidence of sepsis is 32%, with LDLT group having more incidence of sepsis in comparison to cadaveric group. The 1 year survival was low in case, particularly in patients with severe pneumonia. This is another study from Korea which looked into the difference between the partial graft or small graft versus the whole graft. They found the overall incidence of sepsis is 48%, and the incidence of sepsis according to them was more in DDLT, which I am going to discuss later on. And 1 year survival was low in comparison to the patients who had no sepsis. These are the other studies. The studies from our center, they have shown that 314 patients included in the first study. The incidence of sepsis is 40%, with 1 year and 3 year survival is quite good in sepsis group. However, it is there is a decreasing trend in comparison to patients who didn't have sepsis. The recent study, which is in the fray for publication by Bharat from our group, 578 patients were included in that study. The incidence of sepsis is 48% in our group, which looked into early mortality, that is 3-month mortality, with sepsis group having decreased trend of sepsis, though the clinical significance we have not looked into, and in comparison to patients with no sepsis, the survival, 3-month survival is up to 90%. So these are the data on sepsis. Coming to source of sepsis, in our group what we have identified, because the source differs between different hospital settings. So in our group, both the studies, we have identified the ascitic fluid and bloodstream infection are the common source of infection. Coming to the risk factors which are associated with sepsis in the setting of liver transplantation, both LDLT and DDLT, I am going to cover. This is one study published in year 2018, which we have already discussed. It included both LDLT and DDLT patients. 48% of the patients are infection, and with a good follow-up. 1 year mortality is 24.7% in patients with sepsis, so which is more than 8% in non-septic group, and they have got increased admission and hospital stay. And the source of sepsis is again intra-abdominal infection, as in our group is almost 20% of the patients had intra-abdominal infection, followed by catheter-related bloodstream infection and bloodstream infection without catheter-related and pneumonia accounting for most of the cases. The factors which were responsible for sepsis, that means the risk factor for sepsis, they found that the high MELD score and deceased donation has got high risk of sepsis, with odds ratio being highest for deceased donor liver transplantation in comparison to live donor liver transplantation. And acute rejection, as you know, is associated with increased immunocompromised state in view of the pulsing and steroid and the other escalation of immunosuppression was associated with increased risk of infection. In another study published in 2016, 63 patients, 29 patients had sepsis. Again, this group looked into severe sepsis group, and their survival, it was quite low in comparison to non-sepsis patients. And patients with sepsis subgroup also have survival, 5-year, 10-year survival also low in comparison to no sepsis group. And these are the sites of sepsis, and they looked into the factors which will preempt sepsis or are risk factors for sepsis are avio incompatibility and lymphocyte count of less than 850. This is another study which looked into the partial graft and whole graft by the German group. They looked into two infections, that is pulmonary and bloodstream infection. Pulmonary infection were present in 18% of the patients with the LDLT and only 5% patients with DDLT. And in bloodstream infection also there is an increased risk in LDLT, though it was not statistically significant. These are the definitions they used for the pulmonary and bloodstream infection. They found that the sepsis affects the survival, particularly in patients with severe pneumonia. The sepsis group resulted in a very low 1-year survival, that is 42%. This is another study which included 136 patients. They tried to identify the markers which identify sepsis, and they looked at serum PCT level in patients with sepsis and non-sepsis group. And the survival again was lower in sepsis in comparison to non-sepsis group. In univariate analysis that looked into this scores, that is MELD score, pre-transplant ICU admission and pre-transplant RRT and WBC count, all were significant in univariate analysis. But however, the multivariate analysis revealed the procalcitonin level with a high odds ratio with the predictive factor of sepsis. Coming to small first size syndrome and sepsis. The sepsis as per se is not included in the definition of small first size syndrome, and because it's actually excluded from small first size syndrome. However, small first size syndrome can lead to early allograft dysfunction, which can be a nidus for sepsis. So regarding the literature, I couldn't find direct evidences of small first size syndrome leading to increased evidence of sepsis. However, does low liver mass leads to sepsis? Probably yes. One study published in 2004 in liver resection patients, they looked into the percentage of liver RLV, that is remnant liver volume, and the incidence of sepsis. What they found is the incidence of sepsis is more common in patients with lower liver remnant, which leads to severe hepatic dysfunction. And the incidence of infection in those patients with severe hepatic dysfunction were higher. So indirectly we can say the low liver volume leads to increased incidence of sepsis, but we don't have much direct evidence on that. However, I would like to quote two papers in which particularly they looked into small first size syndrome patients, this cohort they published in year 2021 this study. 258 patients who has got small first size syndrome with portal hyperperfusion. They looked into preoperatively low predicted graft volume and standard liver volume ratio less than 35%, or patients with severe portal hypertension as identified by a large portosystemic shunt and splenomegaly and high risk patients.
You need to summarize soon.
Yes, I would move. So the frequency of sepsis was 18% in patients who had splenectomy. So they tried to say that patients who underwent splenectomy had lesser incidence of sepsis in comparison to previous notion that splenectomy is associated with more incidence of sepsis. So indirectly this gives evidence that yes, small first size syndrome has got more incidence of sepsis, though it's 18%, but they still try to reduce that incidence by going for portal flow modulation. This is another study which looked into the incidence of not exactly they directly looked into sepsis, but they looked into the overall complications, severe complications according to the GRWR. They divided into three groups. The group 1 with low GRWR, they had more inflow modulation and in comparison to other groups. They found that the overall complications, severe postoperative complications, were were similar between both the groups. So there were no difference between, but this group had got selective inflow modulation in patients with low GRWR. Regarding pediatric population, the incidence of sepsis is quite similar to that of adult. I would like to quote two studies. One study which claimed to be the largest number of pediatric transplantation. The incidence of sepsis in their group was 26%, and this sepsis is significantly affects the outcome of the transplantation. That is, the sepsis is responsible for 35% of the mortality in their group. Another study I would like to quote is 173 patients who had LT. The bacterial infection, the mean age in their group was 2 years. Bacterial infection were responsible for sepsis in 77% of the patients, and they suggested that multi-drug resistant infection is associated with severe sepsis in their group, which includes VRE and extended spectrum beta-lactam producing. This is very recent study, sir. Yes, sir. This is the role of AI. I'm going to rush through another 4-5 slides, sir. Use of AI to predict sepsis early before the true onset of sepsis. Huge number of patients has been included, recently published. 5,748 patients. They used physio markers as the on a minute by minute physiological data streams to look into these parameters, clinical parameters and laboratory parameters. So what they found is that heart rate, respiratory rate, systolic blood pressure and mean arterial pressure changes can actually preempt the onset of the sepsis. So this is the among three physiological signals: respiratory rate, diastolic blood pressure and systolic blood pressure. 12 hours prior to sepsis can predict the onset of sepsis. This is I'm coming to ILVS data, just 3-4 slides. 314 patients, all ABO compatible live donor liver transplantation. 40% had sepsis. The median onset of sepsis day was 7 with interquartile range of 4 to 11. This this is actually looked into the lymphocyte, neutrophil lymphocyte ratio as a marker for onset of sepsis. When we look at the graft, type of graft or smaller graft or GRWR, whether it affects sepsis or not, there was actually no difference between the incidence of sepsis in these groups. In fact, the GRWR between sepsis group and non-sepsis group were almost similar with no significant difference. However, mortality was definitely higher in patients with sepsis. So in that paper, NLR was found to preempt sepsis than the other factors, the isolated factors like neutrophil count, lymphocyte count, and thrombocyte. Coming to the sepsis in ALF, the incidence is almost 30.
Nihar, we have to conclude now.
Yes.
Just give your last slide, please.
Yes, sir. This is our study which is going to.
I know the study.
Yes, sir. So incidence of sepsis is 48% in a larger cohort of 578 patients, sir. And coming to the post-transplant severe sepsis, it's 23% severe sepsis. And the coming to sepsis-related hospital mortality was higher in patients. This study actually looked into the preoperative pre-liver transplantation sepsis, the timeline of sepsis affecting the outcome in our patients. And these are the source of sepsis in this cohort with bloodstream infection and urinary infection and chest being the ascites, that is abdominal drain fluid being the major site of sepsis. So coming to the predictor of mortality, we have found that male sodium more than 25 is the predictor of mortality, and pre-LT sepsis within 28 days has got a high odds ratio of mortality, whereas post-op severe sepsis didn't affect mortality in the multivariate analysis. Coming to the summary, evidence of sepsis in small graft is not abundant. As per the literature, though, there is no increased risk in smaller graft. However, larger cohorts should be taken into consideration for study. Partial and whole liver graft, conflicting result, as I have shown in 2 papers. Probably that is experienced in those papers because Eastern centers showing sepsis is more common in DDLT, whereas Western centers showing more common of incidence of sepsis in LDLT. That could be because of the experience of the centers. On the GRWR and sepsis, we really need more evidences and categorization of GRWR and looking at sepsis. Coming to definition, we should use sepsis 3 guideline as of now. And the incidents up to almost 50% will experience some at least one episode of sepsis. And sepsis accounts for more than 50% of the mortality, as has been noticed in our study with larger cohort. Obviously, the early detection and management is vital in case of sepsis. Thank you.